And you may say words that, are not the most politically correct, or we probably shouldn't, yell out loud, but it really hurts sometimes. And if that's how we're coping, we may not choose to use those words chantingly because we could offend, but, it's real. And finding what works to help you through it is what's the important part. And I've said this before, if you find it's that ritual, that routine, and you're doing it over and over again, and it seems to be allowing you to get through a contraction, have that resting period, and then manage the next contraction, don't change things. So, partner, don't say, oh, well, why don't we try this? Or in the middle, if you're rubbing her back, decide, oh, maybe I should rub her foot. Just keep it exactly the same as what is working, because that's an easy way to recognize that, no, the laboring woman is coping with everything that's going on. So you get to that pushing stage, and we want to consider, and I mentioned this before, the directed pushing versus spontaneous pushing. So when you actually have that urge to push, that uncontrollable urge, that is your spontaneous pushing, and that's usually when you will be the most effective. When you are being directed to push, in that you're fully dilated and doctor or midwife is saying, okay, you're dilated, so with the next contraction, we're going to take a big breath in and hold it, and we're going to bear down and push right into our bottom. You're going to push down in your bottom like you're having a big bowel movement. And this is something you hear, and you have that option of saying, I don't want directed pushing unless my pushing is not effective. That there's a difference between being told, no, you have to push now, versus, no, you need to push more here, or doctor or midwife inserting a finger into the vagina as you are pushing and instructing, push my finger out, because sometimes we don't realize actually where we're pushing. And by the doctor or the midwife putting a finger in the vagina, you can feel it and say, oh wait, no, that's where I need to be pushing. So that's a different type of directed pushing versus, okay, you're fully dilated, we need to start pushing now. Once you have that urge, those pushes become much, much more effective. And if you start pushing from the moment that you're fully dilated and really don't have any urge, chances are you're going to tire out, because it will be a much longer pushing process. So as you are pushing baby down, baby is coming. So I'm just going to, this is umbilical cord, I'm going to detach it because it's much easier for demonstration. So we're going to hope that baby has gotten into the proper position, which is back to back. And baby is descending down into our pelvis. The challenging part is getting the baby's head to come up through the pelvis. Once you've got baby's head under that pubic bone and starting to come down, the pushing is more effective. At that point, when baby's head kind of starts to come down under that pubic bone, you're going to start getting more sensation of burning in the vagina and down in the perineum, because the head is protruding almost towards your bottom more so than the vagina when you're actually physically watching a delivery happen. And you're getting a lot of pressure. People will say it feels like you're having a very large bowel movement. It's a brick. It's not a bowel movement. It is the largest thing you've ever imagined trying to come out of your bottom. That's the sensation. It's not a large bowel movement. It feels more like a brick trying to come out of your bottom than a bowel movement. But it's a pressure. It's not even a pain at this point. It's a pressure. And because if you've never experienced it, part of it is unknown of like, oh my gosh, is this all right? Am I going to split? But you're not. But these are the thoughts that go through women's minds. So as that baby's head comes out underneath that pubic bone, it gets a little bit easier to get them out. But you will start to get some burning and some stretching and even more pressure as baby is starting to come forward. So you will often hear your doctor or your midwife at a point tell you to stop pushing, especially as baby is starting to do what's called crowning, which is the largest part of the head is starting the vagina. It also, when baby is crowning, what can happen as you're starting to push the baby down is baby's pushed down, and you can see the baby's head as mommy bears down and the vagina opens, but the head then kind of retracts back in when she stops pushing between the contractions. That's a natural way that you actually want things to go, because it's slowly stretching the tissue to allow the space for baby to come out, as opposed to just kind of shooting the baby out where it just kind of snaps like a rubber band that you've pulled too tight. Sorry, Claire. But
can you stop at that moment? Like, you are able to stop?
You are. Sometimes it is difficult, and that's when this next part's going to be important. So they're going to tell you to stop pushing or just have very small pushes. So there's two kind of ways you can do it. You can blow it out, so it's and it's so that you've got a little bit of force as you're exhaling, and it will cause slow little tiny pushes, or you will just kind of bear down slightly. It can be difficult, but you can do it. And the intense burning that you get is also something that makes it really challenging, because you go from having this intense pressure to what we describe as the ring of fire. And basically that is when the largest part of the head is coming out and the vagina is stretched to its max. And it literally feels like a ring of fire. It's a very, very strong, intense burn. But when you feel that, this is where it gets good. When you feel that, the next thing you're going to get is pretty much intense relief, because baby's head is going to be out of the vagina at that point. When the baby's head comes out, they're going to check the cord. They may do some minor suctioning to baby's mouth and nose on the perineum. And with your next contraction, baby's out. It's getting the head out. That's the challenging part. That's why when they're doing those head measurements on babies in ultrasound, you're like, stop measuring, I don't want to know how big this head is. But the other thing that is, nice is that their head is made up of 5 plates of bone that are not fused together. So it doesn't come out perfectly round and solid usually. It molds, and you can have a little bit of coning to the baby's head as they are delivered. And part of that is because it molds to mommy's body as it is pushed down and out. So when you hear your doctor or midwife say, okay, stop pushing now, just pant, blow out, do whatever you can to try, because it really does help and save your bottom and your perineum. Having said that, there are times where a skilled doctor or midwife is going to look at how a woman is pushing and how her tissue is starting to stretch, or baby is in distress and they really need to get baby out, where they will encourage mummies to get an episiotomy. I'm mixed on episiotomies. There is a time and a place that they are very appropriate, but routine episiotomies are a bad idea. It's actually better for mummy to have a tear, usually, than it is to actually cut mummy. And the reason for that is it actually heals better if the tissue tears naturally where it needed to. And with a skilled midwife and doctor like we have here, they will look and see how a woman is, the tissue is stretching and possibilities of a tear, and make an estimate of, look, she'll be fine if she has a tear, versus, no, we should really make a cut. It's okay to request that you don't have an episiotomy. You can say, look, I'd rather tear, and if your doctor or midwife strongly recommends, they usually will be able to, between contractions, say, look, I'm looking at this tissue right now. If I let you tear, your risk of a worse tear or a tear that could cause further complications will be worse than if I make a small incision, which is the episiotomy. That's a different case. But for the most part, it is better for a woman to tear, and the tearing is usually less extreme than if the episiotomy was there. Any questions about that, other than how do we really make all of this not happen? Well, I don't like them, and I was threatened with one when I was in labor with my son, and I just, the knees almost went shut, and I looked at my doctor. There's all kinds of room down there, I know, the child I was having a prem too, so it was a small baby, and it was like, I know there's space, just give me time, like, I'll get him out, just don't cut me. And the midwife that I was working with was very supportive. She said, I think just give her 2 more pushes, and if she hasn't made more progression with the baby, then, we'll do something. Because with a prem also, and sometimes if you've had a lot of pushing, you can sometimes get quite severe coning and even some swelling on the head that will take place. And we don't want that for babies, especially if they're premature. We want them to kind of come out a little faster so we don't have these, swelling and bruises and things that are uncomfortable for them. And, they can kind of stretch the tissue for you a bit more dramatically. But yeah, sometimes you kind of even need that thread of like, we're going to have to give you an episiotomy if, we don't get that baby moving. And sometimes just hearing those words, it's amazing how much power you can find in you to just, push through and get baby out. Leading up to delivery, having good nutrition, exercising, getting into those squat positions. There are things like perineal massage that you can do. Sometimes as that belly gets harder, it becomes a little more challenging. So you do need the assistance of your partner. You can use different oils, and it is a stretching and rubbing of that perineal area and that entrance to the vagina. There are good instructions that you can usually find online for different ways of doing it, and in a lot of the different maternity books that you may have will have some descriptions on it. Some people absolutely swear by it and think it makes a big difference. Other people, they think it doesn't matter. So it's, look into it because it is something that can help things. Also, having good, strong pelvic floor muscles, having done your Kegels throughout your pregnancy, keeping those muscles strong will help with regards to reducing some of your risks for tearing and needing that episiotomy. We're still doing okay?
Yeah.
It's just that bit of it. I found it goes.
And you know what? I really think that most women, that's a huge fear because it's normal. I mean, you hear these horror stories about women who've had negative experiences, whether it's been with an episiotomy, they've had a severe tear, and it becomes very, very scary. A lot of women don't tell you, though, that wasn't the bad part. It was the fact that they ended up with hemorrhoids from pushing that is more uncomfortable than having a tear. It's very glamorous trying to have a baby and get them out of our bodies, and it can wreak a little bit of havoc. But it usually goes back. Sometimes you might need a little help to get everything back, but that's what our bodies are designed for. And there is discomfort after having a baby, but there's lots of ways of managing that, and that's another important thing. So yes, it's going to be uncomfortable potentially, but there's lots of things we can do to make it less uncomfortable and make that discomfort a less amount of time. So baby is out. This is the good thing. You've got this beautiful, new, fabulous little boy or little girl, and they've been swooped right on your chest, and they're looking at you and probably crying, and they may not be crying, and that's something to be aware of. When babies are delivered, sometimes they don't cry immediately. Sometimes they're very blue or very purple, and it's because they haven't started to breathe yet or deeply breathe to get their circulation changing over from when they've been inside of mommy. So it's quite common that they don't, it's unlike in the movies, babies delivered, you don't immediately get that, it might take a few minutes or you'll get a little, and then there won't be anything, and then baby might, one little cry, and it takes a few minutes before you get that aggressive crying. And that's normal. It doesn't mean there's anything wrong. And the first thing a mom, why isn't baby crying? And they get very nervous. It can be very normal that they haven't, as soon as their head kind of hits the air, hasn't started to cry. They will sometimes have blood on them because there's usually blood involved in the delivery. Sometimes they will have a thick coating on them, which is called vernix. It's a cheesy or waxy-like coating that is on them when they're inside. The earlier they are, so the further away from your due date you are, they'll have a thicker coating usually. And if you're closer to your due date or past your due date, there will often be less of it. Don't be alarmed. It's wonderful stuff. It's why baby's skin is so soft and fabulous. It's there as a barrier. Don't bath them right away, despite what many people will say. Let them be dirty. They need that on their skin, and it's really, really good for them. So don't be alarmed if you get this little scrunched up, wrinkly, purple, cheesy looking child going, wait a minute, this is not what the photos look like. This isn't what I signed up for, but that's what they're supposed to look like. Chances are, though, you will see that baby, and it will be the most beautiful thing you have ever seen, and you won't even notice any of the other things, and partner will have diligently taken a photo for you, and you'll look back going, oh my gosh, that was all over the bit. How did I think you were the most beautiful thing? You were so purple or squished. But that's very common. So it's great when baby is then delivered right up onto mommy, because your work's not done yet. Now we have to have our third stage, which is the delivery of the placenta. You're still going to have some contractions. They are not as strong and intense, usually, as the ones that you were experiencing previously in labor and your delivery process. The placenta is usually delivered, they want it delivered in at least 30 minutes from birth. And when babies, sometimes it's when the shoulder is delivered, other times it's as the placenta is being delivered. They will give you an injection in the leg of Pitocin. This is one time that Pitocin is actually really beneficial in labor and delivery, because what it does is it allows the uterus to keep contracting. Because sometimes when that pain goes away, because baby has been delivered, you kind of stop releasing the hormones as strongly. And it's really important that that uterus keeps contracting. Because in your third trimester and during labor and delivery, roughly a liter of blood in a minute is circulated through the uterus and the placenta. That's a lot of blood. We need that uterus to keep contracting so that a woman doesn't hemorrhage and bleed out. So they give you an injection to make sure that that uterus keeps contracting. If it's not contracting the way they want it to, they will often do some massage. So they'll take usually the side of their hand with the pinky finger, and they will reach in and rub down on the top of the uterus to kind of irritate it, basically, so it will start contracting more. So once that placenta is delivered, then they will inspect the vagina and the perineum to see if there was any tears. If they did have to do an episiotomy, this would be the time when they would repair it. So if they have to do any repair, they'll put some freezing in. That's not very comfortable. I apologize, because it is a needle into an area that's already quite tender and irritated with freezing that goes in. But then it's a little more pleasant because they do the repair, and then you have some freezing basically in your bottom for a little while, so you have some reprieve of the discomfort that has just taken place. So once the placenta is delivered, usually they will leave mom and baby to kind of rest together for a little bit. This is a great time to do breastfeeding, just some bonding. Sometimes they will take baby from mommy for a few minutes so that they can just wipe the baby off, do baby's measurements, give the vitamin K injection, which is given to help with clotting, do a weight check, and then bring baby right back to mommy. So that is labor and delivery. Any questions at this point? Have I scared you, or have I made you feel better?
A little bit better. Now you know it's fine.
Yeah.
Also, with regards to the delayed cord clamping, that is something that they certainly do here, and you just have to vocalize about it. Partners are encouraged, if they want to, cut cord. They don't have to. Some parents like the idea of it, others are just like, no, that's it's not, you're not cutting through like a spaghetti noodle, which it looks like a really big fat spaghetti noodle some of the time. It's like proper cutting through like a piece of meat. Well, no, the reason I say that is because you'll have people that are like gung-ho to do it, and they go to cut, and oh my god, like it's tough, like how do I get through that? So, if I tell you these things, then you're not kind of like, no, I don't want to do that, or okay, I know what to expect. And that's part of it. It's, the whole book series that came out, what to expect when you're expecting. That's a big thing. Sometimes by knowing what to expect makes a big difference. So, a couple of different things to now talk about. So, we've talked about going into labor, what we're going to experience. So I'm going to give you a scenario, and I want you to interject when you would do different things, possibly. Let's just practice. So, this is a labor rehearsal. So, you wake up, you're 39 and a half weeks, wake up in the middle of the night, you get up to go to the bathroom, and you notice when you wipe that, there's a bit of discharge there, it's kind of mucusy and maybe a little bit pink. What are you going to do now? Yes, exactly. We're going to go back to bed. So you go back to bed, and as you'll notice, the further you get along in your pregnancy, you might have to get up a few times in the night because your bladder just can't hold the urine anymore than it used to. You get up to go to the bathroom, and you sit down on the toilet, and you start noticing, I've got that's a little cramp there. Oh, okay. And so you kind of get up, and maybe I'll go get a drink of water. So you walk out to the kitchen. Oh, there's another cramp. But, it's not too bad. Are you going to stay up at this point or go back to bed? Okay, good. Good. It's working. Yep, we're getting it. We're not going to wake our husbands. We are not going to call family. We're not going to pack the bags. We're not going to start pacing to get things going. We're going back to bed. All right, so you've now slept through the night. It's 7 a.m. People are getting up, getting ready for work. You're getting up, getting coffee, breakfast, whatever. You kind of notice, I'm still having those cramps. So spend about an hour, getting cleaned up, getting some food, partners there, and kind of this is kind of happening regularly. But you can kind of keep moving. What are we going to do at this point? That's fine. You're allowed to make that decision. You're in labor. It may be early and you could have 3 days off, but yeah, that's fine. And
you have to overnight somewhere.
Yeah, that makes a difference. When you have to travel with work, you might want to say, okay, I don't know if you should go anywhere today because this is what's happening. But you carry on about your day, basically. You may touch base with your doctor or care provider saying, this is what I experienced overnight. I'm comfortable. You may let your support person know, other than your partner, if you have somebody else, this is what I've been feeling, but I'm okay right now, or, I would like the added support to just kind of get through whatever is coming. So, it's 1 o'clock now, and, you've had a pretty good morning. Contractions are getting a bit more intense, but you're still managing okay, and you have, some lunch, you've got things ready, and all of a sudden, these contractions start picking up, and they're getting to be more intense, but you're okay, but they're still regular. At this point, what are we going to do?
Just keep doing your life.
Yep. Start timing them. If they're starting to become more regular and increasing in intensity, it's just continue doing what you're doing. Your doctor, if you had contacted them earlier, or your midwife to say this is what's going on, they may have given you the instructions at that point that if things are getting stronger and more regular, to let them know, because when they are getting quite regular and stronger, you are moving into that active phase of labor. And sometimes it can go, even for first-time mummies, it can go by really quickly, and you can be ready to deliver sooner than you thought. So the contractions now are really requiring your full attention. Your water has broke, and you're having trouble coping with the pain. What are we going to do now? Perfect.
Get the bag and go.
Yes, and be prepared that the car ride can be very, very uncomfortable. The car ride was very, very uncomfortable. Once I got to the hospital, the pain went away magically. I'm like, wait, what? sent my husband for food because literally the contractions stopped. I was prem labor, so they weren't letting me go anywhere. So he went for food. He came back. I needed to use the bathroom. Went to the bathroom and couldn't get back up from the toilet because the contractions were so intense. I thought the wheelchair handicap railing was coming off the wall. It didn't, and I got up and I went from 3 centimeters to fully in 45 minutes. So, it can be fast and furious, but that car ride, you may have been coping okay in the house, and your car ride can be really out of control for you, just because of the movement, the position you're sitting in, and then once you get to hospital, you don't get angry at yourself or frustrated that if all of a sudden, it's not that bad anymore, or, well, I feel better, it's because you've had that change, and your husband's not erratically driving on the potholes and flashers on and trying to get there. All right, now, that is your basic normal labor and delivery. Sometimes that's not always the case. Sometimes we end up with things that don't go the way we anticipate them to. And that's something that we do need to think about ahead of time because there's nothing that can end up making things worse than that unknown. So sometimes we go into labor before we're supposed to. Sometimes because the position baby is in, we end up with a C-section. Sometimes while we are laboring and so forth, whether we've had, pain medication or we've needed an induction, so we have other things going on, we end up in a situation where, there's stress, end up going for a C-section. Sometimes it takes baby a little bit longer to adjust after delivery than we anticipate. And so just kind of going over some of those things can make it a little bit less stressful. So when we talk about inductions and the need for getting a baby out sooner than they're supposed to, there are some standard guidelines. And the newest regulations from the American College of Gynecologists and Obstetricians is that there is no elective inductions done before 39 weeks. And that's been within the last couple of years that they have implemented that. So if you have a doctor or a midwife who is encouraging you to have an induction before 39 weeks, that is not standard care. Now, if there are issues with the placenta, if there are issues with the fluid volume, if there are issues with mom's health where her blood pressure has gone up or she has some other things going on, you may be appropriately induced or delivered at an earlier stage. But to have an induction because doctor's going on holiday, because mom's getting uncomfortable, I'm tired of being pregnant, can we just get this baby out? These are not good reasons for an induction. And you can end up with more complications by having an induction that is not really medically necessary. When you have an induction, you do have an increased risk, especially if you have not been assessed properly, to end up in a situation where you have to require forceps delivery, vacuum delivery, baby is not tolerating, you end up with an emergency C-section, and there can be further complications afterwards. So you want to look at, why am I being encouraged to be induced, or why are they saying I should have a C-section? With regards to some emergencies that would cause you to, go to the doctor and they're saying, look, you know what, this is not good, we have to get baby out. Your preeclampsia, or what we call HELLP syndrome, which is elevated blood pressure with swelling and some other organs that are involved that is causing problems. That's a situation where we want baby out because mommy's health is at risk. When mommy's health is at risk, baby is at risk as well. If your placenta is not in the right place, so if you, and you would know this at this point, but if you had something called placenta previa, which is the placenta is actually over the cervix, you would not want to let mommy go into labor, because if mommy goes into labor and starts dilating, she's going to bleed out of that placenta. So that's a situation where you would want to have a booked or an elective C-section and before kind of that 39 weeks potentially, because the risk is so high of mommy having complications. If you have a placental abruption, you would want to be immediately absolutely rushed in for a C-section, and that's when you're going to see bright blood. You could have quite severe pain in the abdomen, but if you were passing a lot of blood, that's a time when they would suggest, no, we need to get this baby out, that you kind of don't argue. And then there is something called an umbilical cord prolapse, which is basically if baby's head is not down into the pelvis far enough, what can happen when the waters break, or if the midwife or doctor breaks the water, is the umbilical cord actually comes down ahead of the baby's head. You then have to go for a C-section because there is no safe way to get that baby out at that point, because as baby's head comes down further into the pelvis, it's going to cut off the blood supply and oxygen to the baby because of where the umbilical cord is. So those are just a few times when it's absolutely imperative that you would be going for a C-section. When you look at a medical induction, so if you are post-dates, so you've got to 40 weeks, might be 41 weeks, 42 weeks, there's no sign of, baby really trying to enter the world, and it's like, okay, child, like, you need to evacuate the premises, or you are, at that 39, 40, 41 weeks, and maybe there's an issue with baby's fluid, or, you're not noticing quite as many movements, and there's some concern. So you might be looking at an induction. And with regards to a medical induction, there are a couple of things that are good to consider. So I put these two little slips of paper. One is called a Bishop's score, and then the other is your APGAR score, which is the score the baby will get when they've delivered. But with the Bishop's score, that's something you'll often hear doctors and midwives speak of. And what it is it's the likelihood of a successful vaginal delivery with induction. So based off of what your score is, gives you the success rate. So a number greater than 5 in your point system is what you want, because your chances of a successful vaginal delivery are much higher. The lower that Bishop score number is, the more risk and less success for a vaginal delivery. So there's a few different things that they can do to start the induction process that aren't necessarily a medication type induction. So one of the first things that an obstetrician or midwife can do is what we call sweeping of the membranes. So that cervix would be approximately a centimeter dilated, and what the doctor or midwife is going to do is do an internal exam, but she or he is going to sweep around the entrance of the cervix by the uterus to separate the bag of water, basically, from the edge of the uterus. This can be very, very effective. If a mom in her past has ever had to have any procedures done on the cervix where there might be scar tissue, sometimes doing that sweep and stretching of the cervix a little bit can really help start labor along. Mommy might be having contractions, but it's not opening because that cervix is a bit rigid from having some scar tissue there. It is uncomfortable for mommy, but touch wood, the last several mummies I've worked with in one capacity or another that have had the sweep have then within the next few hours to few days gone into labor spontaneously on their own and delivered vaginally. So it is a really effective, easy way of intervening without necessarily starting with medical management to start an induction. Now, in the book, it also talks about a Foley catheter. A Foley catheter is the catheter that they would put in the bladder. And so basically what they do is they insert that catheter into the cervix. And so the tip would go up into the uterus, and then they inflate the little balloon that is on it to start stretching the cervix out. And once the cervix has stretched and started to open up, the catheter just falls out. Personally, I don't like that method as well as the sweeping, because who really wants to wander around with the catheter hanging out? There's a bit more risk. It's sometimes, you've got a greater chance, in my opinion, of rupturing the membranes, possible infection, and various different things. So I think if you were going to try one or the other, I'd recommend the sweeping of the membranes versus the catheter. But that's my personal preference. Now, there's cervical ripening things that you can do, where you can do, there's theories that you can use different herbs, sex, so the semen with the prostaglandins, those are some of the things that can help. But then also You have the medical side where you can, if the doctor or midwife wants to get things moving along, they would put some of the prostaglandin gel or tablet into the cervix to start softening it to try to get things moving along. In other cases, depending on what things doctor or midwife have tried, and if induction, the other methods had not worked, then you would look at a Pitocin induction where you would be admitted to hospital, you would get an IV, and they would start an infusion of the hormone Pitocin in an IV bag. Usually, if you've got to that point, they have tried other methods, including the prostaglandin in the vagina, and if the contractions had not started or picked up by a certain point, they would then start the infusion of the Pitocin. There are alternatives to induction with regards to more natural things as well. So there's intercourse with orgasm, acupuncture, nipple stimulation. However, the nipple stimulation, just leave your nipples alone because the baby's going to do enough. You don't want them tender before you go into the whole process of breastfeeding. And it takes a large amount of nipple stimulation to actually get things moving along, so just leave the girls alone. If you're bottle feeding, go for it. But we're going to breastfeed, so let's just leave that one to the side. There are different herbs. Some people will recommend eating different foods. Some people will say spicy food. Some people will say pineapple, raspberry beef tea. Another thing that people will consume is castor oil, which can get things going. Some people say it's old wives' tale and like don't do it. It's just going to irritate your bowels. And other people, it's like, no, it worked. I took that. I cleared my bowels out. Next thing I know, I was in labor and I didn't poop. It was great. So, you just have to pick and choose what you want to do. Some other doctors, depending on how far you are dilated, even if you're not fully in labor, they will rupture the membranes because sometimes that will speed things along. And one of the main things you want to consider if they are going to rupture your membranes is what they will say, what station is baby at? And we discussed that in the very first, the second poster. So, if we look back at the pelvis, if baby is kind of -1 even, head is getting down there, but you'd want it down as far kind of as possible before that rupture of membranes because you want to decrease that risk of that umbilical cord coming down ahead of baby's head. You want to make sure that head is nicely down into that pelvis to help protect. The other thing to consider is, depending on what your doctor or midwife's practice is, if you have tried a rupture of membranes in order to try to stimulate labor, what is their standard of, okay, well, how long before I start contracting do I have? So, if nothing has happened in 6 hours, are you then going to put me on a Pitocin drip? Or do I have up to 12 hours, 24 hours? How long can I go with ruptured membranes before you're going to intervene more significantly with regards to this induction? Sometimes, if you've ended up in a prolonged second stage, which is your pushing stage, some doctors and midwives will then encourage a C-section. Every doctor and midwife usually have slightly different allowances. When I first moved here, doctors and midwives really wouldn't let mummies push for much more than an hour, and if they hadn't delivered at that point, they were going for C-section. It has improved where doctors will allow and midwives will allow mummies to push a bit longer because we know that as long as baby is okay, mummy is okay, and progress is happening, there's no reason to rush for a C-section. It just may take a bit longer. But there are times if mummy is becoming exhausted, baby's really not moving down the way they should, and especially if baby is starting to have some what we call decelerations, which is those drops in heart rate, that you may end up needing to go for C-section. Sometimes babies during the whole labor and delivery process can be stressed out. I don't know why they would be stressed. They're just trying to be squeezed out of the body and start life. They were very happy in their nice little home. But sometimes when they're stressed out, what can happen is they will actually pass their first bowel movement inside of mommy. And that's actually fairly dangerous because what can happen is they breathe in and out that fluid fluid, and they're breathing in and out, basically stool-stained fluid. When they're delivered, they take that first big breath in, and it pulls that meconium down into the lungs, and it can cause some very nasty complications afterwards. So when your membranes rupture, if you're at home or hopefully not in the office, middle of the supermarket, one thing you're going to look at is what is the color of your amniotic fluid. It should be clear, basically. If it's yellow, green, that's something you want to make your doctor midwife aware of, and it is definitely a time that you would make your way to the hospital, because when that baby is born, you're going to have a bit more aggressive suctioning done to try to get any of that meconium that has potentially been and fluid pulled down into the lungs out. So that is a time where you might have some things that go on that are a little bit more aggressive than you were anticipating. Depending on baby's position, they move around a lot in there, but hopefully they get into a nice head down position. But sometimes they can end up with their shoulder over the cervix, or they can end up in a breech position where it's their bum. And those are times when, if their shoulder's there, they're not coming out vaginally. You're going to have C-section. And you can have vaginal breech births, but they are not as commonplace today as they used to be. And most practitioners, a good percentage of practitioners, even in the world, have never actually even done a vaginal breech birth, because the standard of care has changed in that we tend to do C-sections for it. Even when baby is in the head down position, they can end up with their head in all kinds of wrong positions, which can make the delivery much harder for mommy and a little bit more stressful on baby. So we want them with their tummy to mommy's back, their chin tucked, and their head down. And what that does is that allows for the narrowest part of their head to come down first. But they can end up with their head kind of flat like this, so it's wider, or they can have their head tipped back where they're coming face first. This is not what you want. This hurts. This is dangerous for them, but sometimes they're too far along for us to really catch and see what's going on before they start down. So ideally, you want them chin to chest and that part of the head coming down first. Even if they come face up, as long as it's that narrowest part with the head down, it's a little tougher to get them around that pubic bone and out, but it's a lot easier than if they're kind of head first, face first down. For cesarean, do you have any questions about cesareans, or what's your knowledge base on need, not need, what happens, what doesn't happen?
I don't know much.
Okay,
Yeah.
so
Something that I don't want to do, so that's why.
well, I'm going to okay, then I'll pretty it up for you. So if for some reason, before you went into labor, they were recommending a C-section, it would be a little more controlled and planned, which is a bit nicer way of doing things, to be truthful. So you would usually go into hospital the night before. They would have you nothing by mouth after midnight. They would take you to the operating theater the next morning. You'd have the freezing put in your back. They would put the catheter in. Once they got you laid down and draped on the operating table, they would then bring your support person or partner in. That person would sit by your head. They would do the procedure, and baby would be delivered. They would show you baby. Baby would then go to the resuscitator, get cleaned up, and then would be transferred over to the nursery. Usually at that point, daddy goes with baby to the nursery and spends time with the baby there while mommy is finishing up the procedure, where they're cleaning out the inside of the uterus, sewing her back together. She'd then be transferred to the recovery room. She'd be there for half an hour to an hour usually. They would check her vital signs and make sure that she's adjusting after having the surgery, and then you'd come back to the maternity floor. Easy peasy. If you're in labor and there's a problem and it becomes an emergency C-section, then people start running around. It gets loud, the lights come on, it gets exciting, and they would wheel you over to the operating theater in your bed. If you already had an epidural in, they would just transfer you from one bed to the other. They would drape you, husband, partner would come in, and then they would do the procedure. They would show you baby would come back, and the same process for mommy You can even hold baby for a few minutes after a C-section delivery, and they don't really do breastfeeding after C-section in the OR here. Unfortunately, you would have to wait until you go back to your room. Daddy can have skin-to-skin contact with baby in the nursery, so baby will be on the resuscitator or what we call the warmer. So it's a bed with this big piece over top that has lights and heater. And daddy can pick baby up and have his shirt off and do some kangaroo care and snuggling with baby. So there's some bonding and it's not a matter of baby being completely on their own. Question?
What's the best way to cut? Because I've heard vertical, horizontal.
Absolutely horizontal.
Horizontal.
You do not want a vertical cut. Vertical is the classic. It is a very old way of doing a C-section, and the risk to mom and issues with potentially having another pregnancy and issues with delivery of that next baby dramatically increase. If you ended up, for whatever reason, having to have a C-section, it does not mean that you couldn't then go on to attempt to have a vaginal birth with any subsequent pregnancies. However, if for any reason you've ended up with that vertical incision on your uterus, the chances of any practitioner, not here but anywhere, allowing you to attempt a delivery is a vaginal delivery is extremely low because your risk of uterine rupture is very high. So usually the incision is made kind of right above your pubic hair line or just in the very top of it. So if you then eventually grow pubic hair back after they shave you, it's hidden quite nicely. But it is a very small scar that is left, but it is a horizontal incision right in the top of the pubic hair, basically.
It's quite a long recovery time.
It can be, and that's one of the other challenges with regards to a C-section. Any time in your life that you have an operation, you're going to have downtime afterwards. You're going to be in a bed. You're going to recuperate. When you deliver a baby via C-section, we've got you up in a bed within 6 to 12 hours afterwards, having to care for a baby. If that was any other surgery, you'd be in bed. You wouldn't have to be getting up and caring for somebody, changing their diaper, feeding them. And so it can be a bit more challenging. Your recovery is usually longer with a C-section, but there are times if you have a complicated vaginal delivery that your recovery time can be as much. And the recovery is very, very individual. Some people, the C-section pain, they don't mind it. After they deliver the baby, they get up out of bed, it's like, oh, that's a little uncomfortable, the first time they get up, but then they're like, the pain is really not that bad. It's not as bad as I thought it was going to be. Whereas other people, it's very traumatic for them, and they're very, very uncomfortable. And the same with regards to a vaginal delivery. You can have mummies that have really minimal damage to the vagina perineal area, but they find it very uncomfortable and it takes them a long time to recover, whereas a mum that's had more significant damage, it doesn't bother them. So it's very individual for everyone. There's a reason why you have a 6-week checkup with your doctor, and we want everyone to basically have 6 weeks of recovery time. It takes your body a certain amount of time to just adjust to everything it's gone through. You'll be very tired after you deliver a baby, no matter what way it is, whether it's a short labor, long labor. Your body's going to be tired. It's been through an intense physical workout, basically. And healing takes time, adjusting, getting your sleep pattern and everything else organized can be there. So, yeah, it's a little more challenging. And for some people, because of their personality and, how they want things, a C-section works better for them. And, that's okay. If they're going into it with an informed understanding of the risks to themselves, the baby, etc., and that's their decision, as practitioners, we need to support, our moms. It's the same thing to me in one sense as breastfeeding. If breastfeeding is not for a family, then why am I going to stress and, pass my judgment saying, well, you didn't even really try. It's like, they don't have to. They know themselves, they know their family, and sometimes the unknown and not being able to control things would actually cause a more traumatic situation for a family than if they were to kind of plan So that's kind of what to expect when it doesn't go the way we expect it to go.
Yeah.
Any questions? Okay. Let's take another little break and then we will do the postpartum period, a bit of breastfeeding, and understanding why baby cries. Good?
Yeah.
Sounds good. Oh, I was rumbling on